Welcome to Surgery Squad's virtual limited open carpal tunnel release surgery. I'm Dr. Jeff, and I will be guiding you through the procedure today. Carpal tunnel syndrome is characterized by a tingling numbness or pain in your hand, and sometimes forearm. It develops due to the swelling of a ligament in the wrist known as the transverse carpal ligament. The swelling of the transverse carpal ligament creates pressure on the median nerve in your wrist. This nerve is responsible for supplying feeling and movement to various parts of the hand. Performing repetitive motions with the hand or wrist over a long period is the main cause of carpal tunnel syndrome, and the condition is more commonly seen in women than men. Researchers have also discovered that other medical problems such as alcoholism, arthritis, diabetes, obesity, and infections could also lead to carpal tunnel syndrome. Today we'll be operating on a patient who has been diagnosed with carpal tunnel syndrome after experiencing numbness and weakness in the palm of his hand and thumb. Now let's put on our gloves and get started. The limited open carpal tunnel release surgery is performed using a local anesthetic that numbs the carpal tunnel area of the hand and wrist. If a patient is nervous or uncomfortable, I'll sometimes use a sedative as well. A sedative is a drug given through an IV that places the patient in a dreamlike state. However, our patient today will only receive the local anesthetic. Go ahead and get the operating area numb. With the wrist anesthetized, we can now begin the operation. I've already tied a tourniquet around the patient's upper arm. Can you go ahead and outline where we'll be making our incision? Looks good to me. We'll be making a 3/4 inch incision at the intersection of those lines. Now take the scalpel and make the incision. Nice! I couldn't have done it better myself. Now we'll spread the incision wider to expose the transverse carpal ligament. This band of tissue is the cause of the problems. Place the retractors into the incision and spread it open. I think you're a natural at this. With the transverse carpal ligament exposed, I'll need you to slip a carpal tunnel guide into the incision. This is a blunt-tipped instrument with a groove on the upper surface to accommodate a special knife. The carpal tunnel guide is placed down the carpal tunnel and underneath the ligament and is used to protect the underlying nerve and tendons. Go ahead and push the carpal tunnel guide into place. Once it's in position, you'll advance our special knife down the guide to split the carpal ligament. As you push the knife forward, you will feel it cutting through the carpal ligament. Perfect! With the transverse carpal ligament cut, the median nerve is no longer inflamed. Now we can begin to clean and close the incision. Go ahead and irrigate the wound. When you're finished, I'll release the tourniquet, allowing blood to flow back into the hand. Great! Now you'll close the wound using non-absorbable sutures. With the wound closed, we'll inject additional numbing medicine around the operating site to help relieve some of the immediate pain the patient may feel after surgery. And lastly, we'll place a small dressing over the wound to absorb any residual blood. We'll immobilize the wrist with a splint and a sling, and after 1 to 3 hours, our patient is sent home to recover. Our patient needs to keep in mind that because of some of the medications we used, he may experience a bit of nausea. He will also be given pain medication to help relieve the discomfort he'll feel in his wrist. Once our patient returns home, he'll be asked to follow specific instructions for driving, exercise, and medication. This will include keeping his hand elevated above his heart for the first few days after surgery. About 2 weeks after surgery, we'll remove our patient's stitches, and he'll be gradually allowed to return to his normal routines in 4 to 6 weeks. And that's a limited open carpal tunnel release surgery. Thanks for stopping by. Why not try out some of the other amazing surgeries here on SurgerySquad.com?
Welcome to Surgery Squad's virtual LASIK eye surgery. I am Dr. Susie. I'll be guiding you through a LASIK eye procedure today. LASIK eye surgery reshapes the cornea to provide improved focusing power and reduce a patient's need for glasses or contact lenses. LASIK is performed with a special laser that's used to change the shape of the cornea, the part of the eye that controls and focuses the entry of light. By doing so, we can focus the light so that the patient's vision is improved. Our patient's already had her preliminary exam. Her prescription hasn't changed for more than a year, and she has no history of eye disease or injury. This qualifies her as a perfect candidate for the surgery. We want to make this procedure as pain-free as possible, so we'll use drops to numb the eye. Can you place a few drops into her eyes? Even with the numbing drops, it's possible that the patient can feel pressure and mild discomfort, but they do help with most or all the pain. Debris can complicate the procedure, so we need to make sure that the area around the eye is clean. Now that the area around the eye is clean, we'll use a device called a speculum to hold the eyelid open wide. So let's get that speculum over the eye. If the patient was allowed to blink, we might cut or burn the wrong area. At this point, we'll also mark the cornea with a water-soluble ink to guide replacement of the flap. Now we place a suction ring over the eye. The ring sucks the cornea upward, making it easier to cut. The patient's vision will likely dim and blur while the suction ring is attached. For this next step, we're going to slice open a flap on the cornea. To make the corneal flap, we use a mechanical microkeratome. This is a fancy name for a blade device that's attached to the suction ring. We slide it across and it cuts the top 20% of the cornea. Here we go. Slide the microkeratome along the track to create a thin flap in the cornea. With the corneal flap cut, we remove the microkeratome and suction ring and then peel back the corneal flap to expose the middle part of the cornea. This is the part we'll reshape with a laser. The computer-controlled laser is positioned over the eye. By analyzing our patient's data, we've pre-programmed the laser to tell it how much corneal tissue to remove. A flip of the switch to fire up the laser and the reshaping process is underway. Pulses from the laser will correct the shape of the cornea in less than 60 seconds. The laser makes a slight clicking sound and you might notice a faint smell similar of burning hair. And that's it. Please fold the corneal flap back into the original position, making sure our ink guides match up. Nicely done. While you were working, I went ahead and took care of the other eye. We will observe our patient for several minutes to assure the corneas bond correctly. The cornea is quite amazing in this respect. It will be bonded back to each eye in moments. Even with the corneal flap bonded back in place, the cornea is still vulnerable and could dislodge if the patient isn't careful. That's why we put a clear protective shield over each eye. This keeps the patient from bumping or rubbing her eyes. The patient will notice the improved vision immediately, or as soon as the numbing drops wear off. She may now be driven home as she won't be able to drive for a day or two. She'll come back within the next 48 hours so we can remove the eye shields, test her vision, and examine her eyes to make sure everything is healing up nicely. And there you have it, another successful surgery. You can see more of my superior surgical technique and my other procedures here on SurgerySquad.com.
Hello, and welcome to Surgery Squad's virtual colonoscopy. I'm Dr. Jeff, and I will be guiding you through this colon today. Also known as the large intestine, the colon is responsible for the final stages of the digestion. It absorbs remaining water and electrolytes from indigestible food, accepts and stores food remains that weren't digested in the small intestine, and eliminates solid waste from the body. A colonoscopy allows your doctor to view inside your entire colon using a device called an endoscope. As the scope moves into your colon, your doctor views the output on a monitor to check for growths or polyps. There are several parts to the colon: the cecum ascending, the transverse, the descending, and the sigmoid. A colonoscopy can check each one of these areas. The one thing about having a colonoscopy is that a doctor can find polyps and remove them immediately. This is the most effective way to prevent the development of colorectal cancer. However, you'll need to cleanse your colon 24 hours before the test by taking laxatives or performing a fleet enema. Also, use of the endoscope might accidentally tear the colon walls and cause bleeding. Plus, you'll need to be sedated during the exam, which should take about 30 minutes or longer if any polyps are found. We have a 53-year-old female waiting for her colonoscopy. Let's get scrubbed and take care of this. Our patient is lying on her left side, knees drawn up to her stomach. She's wearing a gown, and we have a sheet draped over her. Let's set her up with an IV drip of the sedative. Great. Now we'll wait a few minutes for the sedative to take effect. Our patient is sedated and ready. She stated that she's cleansed her colon, and I've already used a lubricated, gloved finger to check for blockage. Be sure to tell the patient that she should breathe slowly through her mouth to relax her stomach muscles if she feels cramping. We'll insert the endoscope into the anus and slowly move it into the colon. The endoscope contains a small camera and light, and a pair of forceps so we can remove any polyps we find. First, let's lubricate the scope for easy insertion and passage through the colon. Carefully insert the scope into the patient's anus and slowly move it into the colon. We can watch the camera's output on the monitor. We're into the rectum now. Nothing so far. Let's move on into the sigmoid colon. Slow and steady. You're doing a great job. Descending colon's next. Now's a good time to remind our patient to breathe slowly through her mouth as we do the exam. All right, let's move into the transverse colon. Uh-oh, looks like we've got a small polyp in the transverse colon. We'll use the forceps to remove it. Fine work. We'll need to remove the scope so we can bring the polyp out. First, let's use some heat to cauterize the spot and try to stop that bleeding. Fantastic. Let's slowly withdraw our scope and get that polyp out. Let's go back in to check the rest of her colon. Remember the name of the colon where we found the polyp? That's right, the transverse colon. Back in the transverse colon now. Everything's looking fine, and you're doing a great job. Now's also a good time to remind our patient to breathe through her mouth slowly. Moving now into the ascending colon. And there's another one. Let's take it out the same way we did the other. Back in the ascending colon now, and we move into the cecum. And all looks good. Let's take out the scope and get our patient into a recovery room. Our patient is now in recovery, and she'll probably be there 1 to 2 hours. She might feel bloated or need to pass gas, and since we removed 2 polyps, she'll probably have a small amount of blood in her stool. We'll also do a biopsy on the polyps. She should call her doctor immediately if she has heavy rectal bleeding, lower abdominal pain, develops a fever, feels dizzy, vomits, or experiences swelling in her abdomen. Well, good news. The biopsy showed our patient's polyps were benign. Since she's in her 50s and there were polyps found, she should have a colonoscopy every year. You did a great job today. While you're here, try your hand at one of our other surgeries here at SurgerySquad.com.